see the temporomandibular joint. See, this is the mandible, this is the condylar process of the mandible, and this is the neck of the mandible. So, we are going to insert here. Can you see, this is the skull, this is the temporal bone, here you have the mandibular fossa. Here only I am going to articulate this. So, temporomandibular joint, while writing the essay, you should write what type of joint it is. So, it is condylar variety and synovial joint. First point you are supposed to write. Number 2, what are the articulating surfaces? So, this is the lower articulating surface, this is the condylar process, and this is the superior articulating surface, this is the mandibular fossa. So, you have written these two, this is the articulating surfaces. Number 3, you have to write about the ligaments. So, what are the ligaments will you write? Number 1, the most important ligament you are supposed to write is a capsule. So, the capsule extends from where to where? So, look at this, capsule extends from the, can you see this? This is zygomatic bone. Here you have an eminence called articular eminence or articular tubercle, this one. Okay, so this capsule comes from the superior aspect of this and comes to the neck. So, it will come up to the neck of the mandible. The lateral part of the capsule is getting thickened and forms the lateral temporomandibular ligament or lateral ligament. So, the first you should write the capsule attachment from where to where. Next, you have to write about the lateral ligament or temporomandibular ligament. This lateral ligament and the capsule gives stability to the joint. The capsule, while writing, you have to write about the upper part of the capsule is loose and the lower part near the neck it is tight. That is why it produces a movement in the upper part and the lower part is for the stabilizing purpose. And here in the anterior part it is attached to the anterior tubercle. So, you should know one thing, anterior tubercle is one of the stabilizing factor. So, if the mandibular condyle, if it comes out from the anterior part, it will become dislocated, anterior dislocation. So, it is very important. Then next thing is relations. So, the next these two are the capsule and the lateral ligament are the main ligaments. So, the accessory ligaments we need to know what are the accessory ligaments. So, for that you should know something in the inferior aspect. Inferior aspect of the skull, if you see, this is the mastoid process and here is your, this is the mastoid process and here is your styloid process, right. So, mastoid is here, styloid is here. Just behind the styloid you have a spine called spine of the sphenoid, right. So, this is the mastoid process, this is the styloid process, this is the spine of the sphenoid. The spine of the sphenoid is very important. It from the spine of the sphenoid, apex of the spine of the sphenoid, a ligament goes towards the this is the mandible, this is the lingula of the mandible. So, it goes to the lingula of the mandible. That ligament is known as sphenomandibular ligament. So, spine of the sphenoid to the lingula. The ligament is known as sphenomandibular ligament. Now, the relations to the sphenomandibular ligament, laterally and medial to the sphenomandibular ligament. Laterally, what are the things you have? What is this? This is condyle. This is neck. Neck of the condyle is wound around by a nerve called auriculotemporal nerve. This is the MCQ. Then the next is, here you have the pterygoid fovea. So, the pterygoid fovea, the muscle attached to the pterygoid fovea is lateral pterygoid. So, two relations laterally for the sphenomandibular ligament. This finger is the sphenomandibular ligament and laterally it is attached related to the auriculotemporal nerve and the lateral pterygoid muscle. And medially you can write the most important nerve which goes to the tongue is your lingual nerve. So, this is your lingual nerve, this finger is your lingual nerve. So, what is the nerve attached to the lingual nerve is chorda tympani. So, you should write two important relations. So, this I said, this is the styloid process, this is the spine of the sphenoid. So, spine of the sphenoid, if I articulate here, look at this, I have articulated here, this is your spine of the sphenoid. Spine of the sphenoid is medially related to the nerve called chorda tympani. So, here also your sphenomandibular ligament also medially it is related to the chorda tympani. So, medially chorda tympani, laterally auriculotemporal. So, these two relations you should write, and the sphenomandibular ligament is a remnant of the first pharyngeal arch, Meckel's diverticulum. This word should be there. It is derived from Meckel's cartilage, right? First pharyngeal arch derivative. Then number 3, sphenomandibular ligament is pierced by. Now, you can see a line nicely, there is a groove that is called as mylohyoid groove. This mylohyoid groove contains mylohyoid nerve and vessels. So, obviously, the sphenomandibular ligament is nearby the mylohyoid line and groove. So, this mylohyoid nerve pierces the sphenomandibular ligament. So while writing the sphenomandibular ligament, you should write the attachment from the apex of the spine of the sphenoid to the lingula of the mandible. This projection is called as lingula. This projection, the mandibular, this foramen is called as lingula. So this attachment is here. It is derived from the first pharyngeal arch and Meckel's diverticulum. Number 3, it is pierced by the nerve to mylohyoid. Number 4, laterally it is related to the auriculotemporal nerve and the lateral pterygoid, and medially it is related to the chorda tympani nerve. These are the points you are supposed to write for the sphenomandibular. Next ligament is spine of the sphenoid to lingula, you should write. But the next ligament is stylomandibular ligament. This everybody knows, from the apex of the styloid process to the posterior border of the ramus of the mandible. This is the ramus, and this is the anterior border, and this is the posterior border. Posterior border of the ramus of the mandible, it comes from the apex of the spine of the sphenoid to posterior border of the ramus of the mandible, it comes exactly near the angle, right? This is about the stylomandibular ligament. It is the deep part of the deep cervical fascia. This is the neck. From the neck, your deep cervical fascia goes up. It divides into two portions. One is the upper lamina, another one is the lower lamina. Upper lamina goes to the zygomatic, and the lower lamina is attached from the styloid process to the mandible. That is your stylomandibular ligament. So the stylomandibular ligament, when you write, you should write it is a modification of the deep lamina of deep cervical fascia, not the superficial lamina, deep lamina. Point number 1. Point number 2, it divides the parotid gland from submandibular salivary gland. These two things you are supposed to write for stylomandibular ligament. So 4 ligaments over. In some books, retinacular fibers also given. You can add a word about retinacular fibers. Then relations, the most important relations. Relations, when you write, I will put the mandible here. So first we will see the superior relations. So if you see the superior relations, see, this is the mandible, this is the area of the mandible. So superiorly, what you have? Middle cranial fossa, and you can see the vessels, middle meningeal. Can you see the vessels? Groove. So this is the middle cranial fossa and middle meningeal vessel superiorly, and inferiorly this is a fossa called infratemporal fossa. So maxillary vessels will be having, maxillary artery and the vein. And then now you see the posterior relations. Posteriorly you have the external acoustic meatus, and here you have the very important artery and nerve. Superficial temporal artery and auriculotemporal nerve will be here, because this is the area called auricle. So auriculotemporal nerve and the superficial temporal artery will be here. This is posterior. And then anteriorly you will be having, what is the muscle present here? Pterygoid, lateral pterygoid. So a lateral pterygoid and masseteric vessels and nerves in the notch. So these two structures you should write. So masseteric vessels and nerves here, and then you have the lateral pterygoid here, and very important nerve winding around here is auriculotemporal. So these structures anteriorly. So anteriorly you know, posteriorly you know, superiorly middle cranial fossa inside, and inferiorly mandibular vessels, and medially. So laterally also you have the auriculotemporal nerve is coming over here, and medially what are the structures you will write. So I will take it out, and medially I have already showed you. Okay, first is the styloid process, next is the carotid artery, internal carotid artery is here. So the tympanic part of the temporal bone only divides here. Listen. So one tympanic part of temporal bone, and then this is the carotid canal for the internal carotid artery. Next comes your spine of the sphenoid. Two nerves related to the spine of the sphenoid. One nerve laterally is your auriculotemporal nerve, another one medially is your chorda tympani. So this is the spine of the sphenoid. Laterally it is related to auriculotemporal nerve, okay, because this is auricle, and medially you have the chorda tympani nerve, right? And then here you have the foramen spinosum. Foramen spinosum is for middle meningeal vessels. So medial relations I will tell you. First, tympanic plate of temporal bone only divides everything. So carotid, internal carotid artery and spine of the sphenoid, auriculotemporal nerve, chorda tympani nerve, and then middle meningeal vessels. So these all the structures you should write for medial relation. Laterally, what is the gland lying laterally? Your parotid gland. Skin, superficial fascia and the parotid gland you have to write laterally. Skin, superficial fascia, parotid laterally, and medially I have told all the nerves. Anteriorly lateral pterygoid and the masseteric vessels and nerves anteriorly, and posteriorly I have told you external acoustic meatus with superficial temporal artery and auriculotemporal nerve. So these are the relations you have to write. Then the most important thing you have to write about the disc, articular disc. articular disc while writing. This lies between the condyle and the mandibular fossa. This disc divides the temporomandibular joint into two portions. One is above the disc and the another one is below the disc. This white color is the disc. So above the disc it is for the gliding movement, below the disc it is for the rotatory movement. So this is very important action taking place above and below the joint. This is lined by, as usual, by synovial joints. The intra-articular part of the disc is not lined by the synovial membrane, and the center part of the disc is avascular and non-nervous. The peripheral part only it is nervous and it is vascular. Then next thing is the shape of the disc is concavo-convex superiorly, and inferiorly it is, look at this, the disc is concavo-convex superiorly and inferiorly it is convex. This is about the disc. And the disc anteriorly it is attached to the disc is here. The disc is anteriorly attached to the, what's the muscle present here? Lateral pterygoid. So the disc is anteriorly attached to the lateral pterygoid, and posteriorly disc is, look at this, this disc is attached to the squamo-tympanic. Can you see this fissure? This is squamous and this is tympanic plate. So this fissure is called squamo-tympanic fissure. So anteriorly the bilaminar disc is anteriorly attached to the lateral pterygoid muscle, and posteriorly it divides into two parts, and the upper part will be attached to the squamo-tympanic fissure and the lower part is attached to the mandibular condyle. So you have to mention this. So for the disc you should write the disc is fibrocartilaginous, number 1. Number 2, it is upper part is concavo-convex, the lower part is concave. Number 3, the disc divides joint cavity into upper portion and the lower portion. Upper portion is for rotation, lower portion is for gliding. And then next is the center part of the disc is not covered by the synovial membrane and it is avascular and non-nervous, and the peripheral is vascular. Anteriorly the disc is attached to the lateral pterygoid, posteriorly it is attached, divides into two, and the lamina is attached to the upper part is attached to squamo-tympanic and the lower part is attached to the condyle. Like that you have to write for the articular disc. And then next thing is movement. Movement, how will you write the movement? You have to know the muscles. So the muscle coming from here is your temporalis. Temporalis has vertical fibers and horizontal fibers. So the insertion of the temporalis is here in the coronoid process. So what will happen? Vertical fibers, when they act, it will close the mandible like this. Understood? So elevation. So this is called elevation. So elevation of the mandible is by temporalis. Vertical fibers of temporalis, masseter and medial pterygoid, because medial pterygoid also starts from here, the medial portion of the pterygoid plate to the angle of the mandible. This is angle. So if a fiber is coming from here to here, what could be the action? So this will also elevate. Close. So this is elevation. And masseter, I have already told you, it is coming from the zygomatic bone to this lateral aspect of the ramus. So this will also elevate. So 3 fibers, they elevate. And then who will all depress? Depresses the mandible is lateral pterygoid, because how it depresses? The lateral pterygoid muscle is attached to the pterygoid fovea as well as to the articular disc. So when the articular disc is pulled by the lateral pterygoid, it just slides and then it opens, because I have already told you the movement taking place. So it slides and it opens the jaw. That's why the lateral pterygoid opens. This is opener. So depression of the jaw. The depression of the jaw is again done by the muscle present here is your mylohyoid, and here you have the mylohyoid muscle and the digastric, all the geniohyoid. All these muscles also they depress. So 3 depressors of the mandible. So elevator, depressor and protrusion. Protrusion also done by the lateral pterygoid, and retraction means going back. So going back is done by the horizontal fibers of the temporalis. So temporalis fibers are here, horizontal fibers. So when they pull back, it will go back. So horizontal fibers. So these are the actions: elevation, depression, protrusion, retraction. Side to side movement is done by both the pterygoids, medial pterygoid and lateral pterygoid. And you have, if you want to move only one side, then the action will be taking place in the upper part one action, lower part one action, I have already told. So that will action is complicated for UG students. In my next video, the mechanics I will explain. So for the UG standard, you can write elevation, depression, protrusion and retraction. Then the factors stabilizing the joint. What are the factors stabilizing? One is the muscle, lateral pterygoid, another one is the bony point, articular eminence, and the third point is the capsule. So these 3 are the bony factors stabilizing. Number 4 is the nerve supply. What is the nerve supply will you write? Nerve supply is, what is the nerve? I have told you auriculotemporal. What is the nerve in the master notch? Mesenteric nerve. So mesenteric nerve and the auriculotemporal nerve is the nerve supply. Blood supply is by, as usual, by superficial temporal artery and maxillary artery, both are here, so it gives a blood supply. And what is the clinical application you will write? So if there is mainly the locked jaw in tetanus, the jaw will be contracted, all the muscles will be contracted, so you will be getting locked jaw. And when there is injury, the temporomandibular joint will be coming out of the joint articulating surface, and this is called joint dislocation. So you have to put pressure over the third molar tooth and then you have to retract it, repair it. Okay. So if the ligaments are all loose, you have to go for surgery. And then sometimes arthritis, temporomandibular joint inflammation will be there. So these are the points you have to write for the clinical anatomy. So locked jaw tetanus and the jaw dislocation, anterior dislocation as well as posterior dislocation. If it dislocated, it may injure the auriculotemporal nerve. So this is about the temporomandibular joint. The side headings are type of the joint, articulating surfaces, and ligaments capsule first you should write. Number 2 is the lateral ligament or temporomandibular joint, which stabilizes the joint laterally, then it prevents the dislocation laterally. Then the third one is your sphenomandibular, fourth is stylomandibular. These are the ligaments you should write, and relations I have already explained. And then articular disc separately you should explain. And then last one is movements and nerve supply, blood supply, clinical anatomy. Thank you.